Okay, good afternoon, and welcome to the Best Abstract session. So the IFSO European Chapter Executive Committee did a lot of work going through the abstracts and to select the 10 best papers that are now in this session. And it will be the scientific committee chair, vice chair, and member of the core group that will assess all of these abstracts. And at the end of the session, we will give out the 3 prizes for the best top 3 abstracts. And they're all, of course, already very successful by making it through the cut in this session. So without further ado, we start with the first one.
Okay. So congratulations for all those who are qualified to present in this session. I mean, that is an applause from the very beginning. The first one is ambulation after metabolic bariatric surgery, induced weight loss, long-term results from the SOS study. It's almost famous. That is very interesting. And Dr. Svensson, please.
So thank you very much, and thank you for the opportunity to present our data on ambulation, which is basically the ability to walk, and I have nothing to disclose. And when you lose weight, regardless of which method you use, you're going to lose both fat mass and lean body mass. And lean body mass, of course, consists also of muscle mass. And there has been an ongoing discussion on if you lose too much muscle mass, you might end up as a sarcopenia, and then that might reduce your physical functioning. And this is especially possible if you lose weight many times. But there's little data out there, especially long-term data, regarding physical functioning after weight loss. So I'm working with the SOS study. Many of you might know about it, but a short summary. It started in 1987. That makes it almost 40 years next year. It's a matched prospective control study, and we have a surgery group of approximately 2,000 patients and a control group of equal size, and the control has been treated at their primary healthcare centers. Inclusion criteria were 37 to 60 years, and we had slightly different BMI cutoffs for the SOS than we usually have for most studies nowadays. And they've undergone, both the control and the surgery group has undergone extensive examinations, and up to 20 years, and all these examinations have also included questionnaires. And one of these questionnaires is something called the Sickness Impact Scale, and this has different categories, and ambulation is one of them. And this category consists of 12 items with statements. I don't walk up and down hills, I only use stairs slowly, and the patient has to indicate whether or not this applies for them right now. And then from these 12 statements, a score is calculated. 0 is no disability, and 100 is basically full disability. We also, at least in the later time points, had also the SF-36 scale, and that also has subscales, and physical functioning subscale is quite similar to the ambulation scale in the SIP. 10 items, you have 3 response options. Walking more than 1 kilometer, is that limiting or not? Bending knee and stooping. And also here you can calculate a score from 0 to 100. Unfortunately here, the scales are here reversed. So 0 means severe physical limitation and 100, no limitations. And unfortunately, we have this data on 10, 15, and 20-year examination. So this is one of the classical SOS pictures. This is the BMI over time. And as you see, the surgery group is slightly heavier at inclusion, but we have the sustained long-term weight loss, which the SOS study is famous for. And here's the first data on ambulation. So again, I want to point out, the higher up on the score, the more worse you are off. So in baseline, our surgery group is worse off in ambulation compared to a control group. But after the weight loss, this is dramatically improved. And then after 2 or 3 years, we see this gradual decline over time. And this we interpret as the age-related decline, because our patients are fairly old. But all over time, we have a significant difference favoring ambulation in the surgery group. And I also would like you to point out that if you look at the curves here, that it actually is up till the 15-year examination when the surgery patients are reporting the same level as ambulation deficiency as they had in baseline, 15 years. We have looked at data in different aspects as well. We looked at stratification by sex, and the patterns are the same in both groups, but the females tend to also report slightly higher ambulation deficiency over time. We have looked at stratified by age, and to the right is the older patient above 50, and they also score slightly higher than the younger patients, and also the slope over the 20 years is slightly higher for the older patients. We've also stratified by 1 year weight loss, and especially in the surgery group, this might be interesting, that those that had a more extensive weight loss at 1 year also are the one that actually have the better ambulation. That's the right-hand side of the picture, compared to those that lost less. The surgery group might not, the control group might not be so interesting in this aspect. And finally, we also looked at recurrent weight gain status on our patients. And this was defined as, if so suggest, 30% from year 1, and we used year 4 as a cutoff for these 30%. And to the left, you see the BMI curves on these two groups, and to the right, you see ambulation. So again, those that were able to maintain their weight were also the ones who were better off in ambulation status. And finally, we have some verification data using this other scale, that's the SF36. And basically, we can say the scale is now inverted, so it's a bit strange here, but basically we can say that we are verifying our findings from the first scale also with SF36. And most importantly here is that in the comparison between the surgery group and the control group, we have more than 5 units of difference between those groups. And this is considered to be a clinically relevant difference in ambulation here. So to summarize this, metabolic surgery is associated with sustained improvement in ambulation over 2 decades. And the greater and more durable your weight loss is, the better the ambulation capacity is. And we find no really support for the suggestion that weight loss and loss of muscle mass associated with that might lead to physical impairment in the future. So, thank you very much for this.
Thank you very much. Thank you very much for presenting your abstract in here. I would like to remind you that you have 7 minutes for discussing, and then for presenting, and then there will be 2 minutes for addressing questions.
And you were perfectly on time, so...
Thank you.
We appreciate it.
If any questions from the floor?
May I ask you if you noticed any difference between the procedures, the surgical procedures that you were performing?
Basically,
gastroplasty and bypass.
Basically everything it's very tightly connected to weight loss.
So not any significance in between the two? The 3, I mean.
We have so few of the bypass in the SOS study, so it's not really
We
easy
remember.
to...
Professor Prager.
Yeah.
Great lecture, thank you very much. Do you have any correlation with bone loss or fracture rate?
We don't have, unfortunately, any bone data in the SOS study. We have looked at fractures. We have published that a couple of years ago, but we did not look at ambulation capacity here. So that's a good
Because you would assume
actually.
when you walk better, you have better bone and less fracture rate.
Yes, or the other way around, that you start losing ambulation if you have a fracture. So it could be both ways.
Yeah. You already published that there is an increased
fracture
number
data
of
is
fractures
published,
in this cohort. So how many of the patients initially enrolled in your study are still followed up now?
The last active follow-up was done 2021. So we are no longer collecting data physically, but of course Sweden has this fantastic register, so we are up to 30 years plus on the register side in average for long-term follow-up.
The entire medical community is grateful for.
Yeah.
Okay.
Thank you
Some
very
other
much.
questions?
If not?
Thank you. Next speaker is Dr. Sergio Carandina, exploring the impact of metabolic and metabolic bariatric surgery on reducing hepatocellular carcinoma risk in obesity. Insight from a nationwide French study.
Good morning, dear colleague. I will present our study, a nationwide French study that explored the impact of metabolic and bariatric surgery on risk of hepatocellular carcinoma. I have nothing to disclose. The close relationship between obesity and the risk of some solid and hematologic cancer is well known. In particular for liver disease, obesity starts a cascade of events that start from steatosis until to the hepatocellular carcinoma. In parallel, diabetes and chronic metabolic inflammation accelerate the process, and today obesity has became one leading driver of hepatocellular carcinoma worldwide. And the question is no longer if obesity is linked to the cancer, but the question is how we can interrupt this trajectory. And this is exactly the question of our study. Does bariatric surgery can reduce risk of hepatocellular carcinoma? In order to respond to this question, we performed a large retrospective observational study using the nationwide healthcare system database, the SNDS, that cover nearly 99% of French population, and it allowed a comprehensive and reliable analysis. In this study, we included more than 2 million of adult patients with obesity, and the patients were divided in two different groups: patients who underwent metabolic bariatric surgery and patients who did not. We applied a strict exclusion criteria in order to eliminate confounding factors, including patients with active cancer, patients with pre-existing liver disease, cirrhosis, viral hepatitis at baseline. This make the possibility of focus only of the relationship between surgery and incident hepatocellular carcinoma. This is the study population. In the group in the surgery group, we enrolled 210,000 patients, and nearly 2 million of patients served as a control. And this is the key results. Metabolic bariatric surgery was associated with 74% reduction in hepatocellular carcinoma with a high significant p-value. This is not a marginal signal, this is a very important result. Of course, the first question is this a result is a robust result? For response to this question, we performed a lot of different analytic analytic statistical exam, and the first one was a propensity score matching analysis that confirmed with a high significant p-value the protective effect of metabolic bariatric surgery. The second was a competing risk analysis, accounting for death as a competing event, and in this case the result was even stronger. The third analytic strategy was the use of Kaplan-Meier curve that demonstrated a consistently lower cumulative incidence of hepatocellular carcinoma over time in the surgical group. So across all the different analytic strategies, the result remained consistent. We analyzed several subgroups, and we found that the result remained consistent in patients with moderate obesity, in patients with severe obesity, across the two main surgical operations, Roux-en-Y gastric bypass and sleeve gastrectomy. In the alcoholism subgroup, we didn't find any statistical difference, probably due to the low statistical power and to the underlying disease mechanism. the message is that this protective effect is broadly persistent and consistent. Of course, there are several limitations that should be acknowledged. This is a retrospective registry analysis database, and in this case, the elimination of all residual confounding is impossible. The database that didn't collect the lifestyle factors such as smoking, diet, alcohol consumption level, and longitudinal BMI changes which should impact the incidence of hepatocellular carcinoma. We eliminate all the early events, but in this case, we cannot eliminate all the potential immortal time bias. Another problem with this database that all the patients in certain database are mainly hospitalized patients. We can insert in this case some selection bias and the possible misclassification for patients operated before 2013 could be completely excluded. Despite all these limitations, the magnitude of the association and the consistency of the results across all the analyses makes purely bias-driven explanation unlikely. And how we can interpret this result? Metabolic surgery induces a sustained weight loss that promote a reduction in inflammation and fibrosis, and all these events are in this situation to reduce the hepatocarcinogenesis. So I think that in this case it's not about just weight loss. It's also about reducing the evolution of the liver disease. In this case, the simple message is that metabolic surgery is not only metabolic, it is oncologic. Thank you very much.
Thank you. We already have a question from the floor and a second one probably.
Thank you very much. These are exactly the type of studies we need where we have superpower in a way. So congratulations to doing this.
Thank you.
And you're controlling for many things. The thing that I was worried about when I saw your data is that the surgical group was mean 43 in age, and the control group was mean 57 in age. And the most important risk factor for having a cancer, that is age, isn't it? So I just want to hear your thoughts about that.
We know that, but the majority of patients that underwent obesity surgery are younger than the patient that is the same thing in the general population. I know. I know this limitation.
Congratulations, Sergio. I wish you could speculate why the drug, low anti-obesity drug, shouldn't make the same effect. Is it different, you think?
I don't think that it's different. I think that the most important results of obesity, of bariatric surgery and medication, the weight loss. And as we can see, there is no difference between sleeve and bariatric and Roux-en-Y gastric bypass, because the very important thing is that the weight loss.
Hello. Thank you, Sergio, for this beautiful study and these great results. I have one question. Do you have the BMI in the SNDS data? You have access to BMI? Okay, at baseline. So you couldn't. Okay, and the second.
All the patients in the study had a
question,
BMI greater than 30. We consider all the patients with obesity, independent of the grade of obesity. We have patients with a lot of patients with a BMI slightly greater than 30.
Okay, and you said that you used a propensity score. Which factors did you imply in your propensity score?
A quick reply.
Yeah.
Yeah, a quick reply. We are running out of time.
Age, sex, and okay, and
Initial
mainly,
BMI?
yeah.
Okay, thank you.
Okay, thank you very much. So we're moving on to Juan Jose Hernandez Morante, and he's going to present baseline microbiome signatures and clinical factors predict weight loss response after Roux-en-Y gastric bypass, an explainable machine learning study. Please.
Thank you. Good afternoon, everyone, and thank you for attending this presentation. We're going to talk about baseline microbiome signatures and clinical factors. I need to be brief, sorry. Well, we have nothing to disclose regarding this presentation. Here are the attributions. Well, as probably you all hear now, gastric bypass is a very effective solution for obesity, perhaps the most effective. But also, we know that there is a high heterogeneity among patients. For example, if we establish a threshold of 3% of weight loss, we find that most patients are able to reach it, but some not. So, although we try to identify or to predict which patient is going to be successful or not, we have still some lack about this knowledge. Recent papers, recent works have stated that microbiome can help to predict surgery success. In fact, we have a plethora of studies stating the benefits of plenty of bacteria. At the end, we have kind of information like this. For example, some bacteria, like Proteobacteria, Streptococcus, etc., are associated with greater weight loss, while Veillonella, Varicella, other species or genders are associated with poorer weight loss. And then we thought in the following question, what if a patient has both positive and negative bacteria in his or her microbiome? And that was important, how can we solve this question? Then we try to move from the reductional linear biology to the present interaction in order to evaluate not the association, but the functional topology of biological systems. For example, in these patients, we have some microbiome features that are prone in the patient to losing weight, but others are pulling down the same situation. So what we did, we follow up 143 patients for 24 months. This is the population that complete the follow-up. We evaluated microbiota, metabolome, and clinical, and other sociodemographic characteristics. Of course, we performed several machine learning procedures, and the more accurate model was the XGBoost. And here are some of our results. One of the key findings of our results is that baseline diversity was significantly higher in optimal weight loss, both at 12 months and 24 months. What this represents, in our opinion, this represents a higher metabolic flexibility by part of the patient that may compensate that drastic anatomical and dietary changes. Of course, we also perform this kind of linear studies. If anyone is interested in or have performed similar studies, we found some bacteria that predispose to a resistance to weight loss and the opposite. But here is, in our opinion, the most relevant part of the study. We were able to identify individual features that predispose a patient to gain or weight loss before a surgical procedure. This is a Hull model. We obtained a 91% precision, which, in our opinion, or comparing with other papers, is quite high. And we obtained several important information. For example, systemic inflammation was a key indicator of surgical success, but not as we suspected, but just in the opposite. Those with higher inflammation show the better trend. But in our opinion, this is the key point or the key find of the present work. We are able now to identify the individual factors implied in the surgical success. For example, in this case, we have a patient with a 93% probability of surgery success with several features, for example, short-chain fatty acids, but there is no microbiome feature. In contrast, in this other patient with only a 1% probability of success, there are many other factors, but here, the low abundance of this specific microbiome feature is prone the patient to this kind of resistance. Perhaps I know that this is a bit difficult to interpret, but the most important, how can we translate this to the clinical practice? Then we have performed a tiny app. It's just to demonstrate the useful of our data. When we can introduce the data of the patient before the surgical procedure, and we can obtain this presentation, no, of this prediction. In this case, the patient have a probability of 87% of surgical success. Then, to sum up this presentation, I would like to deliver you 4 messages to take away. First, baseline gut microbiota diversity differs between high and low weight loss responders, suggesting a key role in bariatric outcomes. Secondly, integrating family-level microbiota with clinical data improves outcome modeling, especially at 12 months, at 24 months that are not so reliable. And machine learning reveals complex relationships missed by traditional methods, while SAT models enhance clinical interpretability. Of course, microbiota-based models may aid patient stratification and personalized care. Though it's important to remind that this study was performed in a very small sample, so external validation is still required to confirm our results. Well, thank you very much for your attention.
Thank you very much. Any questions from the floor? I can start off by asking, how did you decide to choose the 16S instead of, for example, a more sophisticated shotgun sequencing?
Yeah, it's a good question. We were working in other fields similar like this to predict with the loss in many other areas. And we had the opportunity to collaborate with a group that proposed us this kind of work. Okay. Of course, the results can be extrapolable to many other areas, cancer, hospital readmissions, etc.
Definitely. Did you take into account diet the patients were having? Because that, of course, has an effect on the microbiota.
It's a very, very good question. In fact, that's our next study. We have the data, we are collecting data, but for this preliminary information, we have plenty of variables. The problem when we perform this kind of machine learning procedures is the number of patients. So, for example, here we evaluated microbiome features. That's difficult to obtain a grid sample. Of course, including at the same time microbiome, metabolomic, and diet characteristic is complex.
And one last question. I know you are added the machine learning concept, but of course, drawing conclusions is very difficult. So it's whether it's association or causation. So I think that needs to be kept in mind when interpreting the results.
It's also true for me that I'm a biologist and not an informatic maths professional. But I believe that the point is not doing only machine learning. For example, in this work, XGBoost is a model. It's like a black box.
Fully understand.
But for that reason, we move to the next step, to the individual prediction, to the SAT values. This is a key point.
Thank you very much.
Thank you very much for your question.
Thank you very much for your talk. So we invite now two authors of the next paper. There is 25 years of randomized clinical trials in metabolic and bariatric surgery, a systematic review that these ladies did on quantity and quality of these trials. So it's Laura Likama and Lisa Genshaler, if I may pronounce correct, that it's a joint effort of the university in Vienna and the universities from Finland. Okay, good luck.
Thank you very much for the kind introduction. As you said before, we are going to present our data on 25 years of RCTs in MBS. It's a systematic review and an international collaboration between Vienna and Finland on the University of Turku. And I'm Lisa Genshaler, general surgeon from Vienna, Austria, PhD candidate. And this is my colleague.
Yes, I'm Laura Liikama, a surgical resident and a PhD student from Turku University Hospital, Finland.
And we don't have anything to disclose. So why do RCTs matter? As we do know, they are the standard for high-quality research by minimization of selection bias through randomization, blinding, prospective study setting, just to name a few. They are the basis for strong evidence-based decision-making, whether we recommend our patients medication, for example, or surgical procedure, which is especially of interest since we do live in an interesting era of OMMs, underlining the necessity for high-quality research in MBS. So in 2023, a systematic review on 2 decades of RCTs in general surgery was published, analyzing worldwide trends in volume and methodologic quality. And they found that not only volume was increasing significantly, but also the quality of research. Also, they observed a difference in absolute and relative volume of RCTs published. So when you look on the left, you can see that countries like the United States and China, for example, were leading. But when you look at the relative numbers, especially European countries like Denmark and Finland have been on top. So the main question was, how strong is the evidence in MBS?
The aim of our study was to examine the quality and quantity of RCT in MBS during the past 25 years. And from our primary and secondary outcomes, here we focus on the absolute number of RCT, the geographic distribution, and the methodological quality assessed by these necessary parameters. Our study is a thorough systematic review where we use these specific search terms in 3 different databases with a 25-year search period. And we included only the directly MBS-related obesity studies.
So everyone is aware of these high-quality RCTs that have been published in high-ranked journals and have defined our treatment paradigm within the past decades. But probably there is or there are more behind these, and the main question was, how many are there really? So when you look at the flowchart Prisma, you can see that we identified more than 2,000 studies, and after applying our in- and exclusion criteria, finally we were able to analyze and include 490 studies in total.
So we observed the absolute numbers of published RCTs in the past 25 years, examined in 5-year time periods, which is 490 in total. And we see a statistically significant increase in the number of publications throughout the years. And between 2001 and 2005, there were only 37 publications, when during the past 5 years, total of 162 RCTs were published. But the growth of the publication volume has clearly slowed down in the past decade. Here is the geographic distribution by the region. When looking at the absolute numbers of RCTs, majority of the publications are from Europe, which is 240 in total. And happily, we can say that research in MBS has become global. And these are the top 12 countries listed by the absolute number of publications globally. United States has produced the largest number of RCTs, 104 in total, but Europe has 9 out of 12 representatives in this list. But the list of the top countries by relative number of RCTs will most likely look a lot different.
So we didn't just analyze quantity, but also did a quality assessment. And positively, we can say that there have been positive aspects, like that the primary outcome was stated explicitly, for example, in almost 100%, and the baseline was present in 95%. But also, on the other hand, there were some kind of negative aspects as well. Here to point out 2 of them, like the sample size calculation was not described in 22% of studies, and the trial objective was not stated in 44%. So as you can see, quantity isn't equal to quality. Regarding follow-up, which you can see on the left, the length of follow-up, the majority had the short to mid-term follow-up from 1 to 2 years, and only few studies had longer follow-up exceeding 5, 10, 20 years of follow-up, which is actually pretty unsatisfying since we're dealing with a chronic disease. On the left, you can see the follow-up rate. The good news is that almost 50% of RCTs exceeded a follow-up of 90 to 100%. But it might be explained through the short follow-up period. We observed a male predominance within the past 25 years regarding first and corresponding authorship in the studies analyzed. But when you see the figure on the right side, you can see that the ratio of female first authors increased significantly within this period. So there still is room for improvement regarding diversity within authorships, even though it's satisfying also.
So why RCTs are still so rare? Surgical trials are extremely challenging to conduct, and the interventions are usually very complex. Also, surgeons might have difficulty to balance their time between work, clinical work and research. And also, surgical RCTs are still extremely underfunded when comparing to other specialities. The guidelines we use and the decisions we make in everyday clinical work are dependent on RCT, and unfortunately, the evidence is still quite limited with a lot of variation. Obesity management with medication is rapidly growing, and we should be able to keep up with the field. In conclusion, it is great to see the increase in the volume of RCTs globally in the past, but instead of producing just high quantity of trials, we should focus on the much needed high quality trials in the future. Thank you for your attention.
Thank you very much for your work, for the way of presenting the paper. If there are any questions in this respect. Yes, Nicola, please.
More than a question, it's my hypothesis. Just to know if you had the chance to see this proportion among Europe and the other countries, if it changed to the, I don't know if you analyzed that, if it's been changing or stays stable. I mean, Europe increased or decreased in comparison to the other continents and countries?
Well, actually, we're going to analyze that by the 5-year, 5-time periods. But actually, Europe and the United States have always been strong. But we observed that it got more international within the past years.
Please.
Thank you for this nice presentation. Do you think that working with big data and machine learning will help to improve the quality of science? Better than randomized trials?
Like artificial intelligence research terms, for sure. Well, we did our best, but I'm pretty sure that it also would make the data extraction more easy.
For sure, AI will help us to manage, especially the follow-up of the data. But design, it is something that you decided at the very beginning. So you said that quality is not quantity and vice versa. So if you are starting now an RCT, what you've learned from these 25 years of experience, What can be changed
Well,
or should be changed? In 2 words, 3.
Maybe in the future we would hope more longer follow-up periods.
Yeah.
That obviously increases the quality, and also analyze as much as different parameters as possible.
But this contradicts with the funding. We have fundus issues.
Yeah, funding still is a big problem. There was also, as we shown, a BGS publication, and we're like surgery in general, but also MBS is still extremely underfunded.
Excellent work. Thank you very much.
Thank you.
Now, next talk is about paragastric block for visceral pain and postoperative nausea after sleeve gastrectomy. A double-blind randomized trial, and sorry for my pronunciation, Abdullah Sik, is it correct?
Yes. Good afternoon. It's a pleasure to be here to present our study. As Lisa and Laura mentioned the previous session, RCTs are the most important and at the top of the Prisma in scientific session, and now we want to present the results of our RCT. No disclosure. As we all know, laparoscopic sleeve gastrectomy is one of the most commonly performed bariatric procedures worldwide. Although surgical outcomes are generally excellent, the early postoperative period is still challenging for patients. Especially visceral pain and postoperative nausea and vomiting continue to be the major problems. Even we use multimodal analgesic protocols. Also increases, which creates another complications. Here, we wanted to focus on the underlying mechanism in pain and postoperative nausea and vomiting. The visceral pain is different from somatic pain. Patients usually describe it as diffuse, deep, and squeezing or poorly localized. These signals are mainly transmitted through the vagus nerve and sympathetic pathways. At the same time, surgical manipulation of the stomach strongly activates pathways related to nose and vomiting. And this slide summarizes the key pathways involved. The vagus nerve is probably the center player here because it carries both pain and nose-related signals from the gastric wall to the central nervous system. Serotonin contributes significantly to postoperative nausea. Dopamine pathways also influence gastric motility and emetic signaling. So the idea was, if we can target these pathways earlier and more directly, maybe we can improve postoperative comfort. This is the rationale behind the paragastric block technique. The goal is not only local analgesia, but also modulation of autonomic signaling. By targeting vagal and splanchnic pathways together, we aim to suppress visceral nociception directly at its source. At the same time, we may reduce the neurochemical triggers responsible for postoperative nausea and vomiting. So theoretically, this technique could provide dual benefits: better pain control and less nausea. And we expected several potential clinical advantages from this approach. First, earlier and stronger symptom control in the immediate postoperative period. Second, an opiate-sparing effect, which is especially important in bariatric patients. And third, earlier mobilization and faster recovery. Before designing our study, we reviewed the existing evidence on paragastric block. The first important randomized clinical trials was published in 2022 by Dias and colleagues. They demonstrated paragastric neural blockage significantly reduced early visceral pain, also nausea and vomiting. And a second trial was published in 2024. Before starting the study, the protocol was registered on clinicaltrials.gov, and also institutional ethics committee approval and authorization results were supplied. We performed the sample size analysis using G-Power version 3.1. This was a single-center, prospective, randomized, double-blind, placebo-controlled study. We included 210 patients undergoing elective sleeve gastrectomy. Patients were randomized in a 1-to-1 ratio into the PG block group or the sham block group. Importantly, Both patients' outcome assessors were blinded during the study period. These were our inclusion and exclusion criteria. We tried to create a relatively homogeneous bariatric population. We excluded patients with factors that could interfere with pain perception, opioid requirements, or postoperative recovery. In the treatment group, we injected 20 milliliters of 0.5% bupivacaine into predefined parogastric points. In the control group, the same anatomical approach was used, but with isotonic saline as a sham block. This allowed us to maintain blinding and isolate the actual effect of the block. All patients received the same standardized perioperative care and multimodal analgesia protocol. This was important to minimize confounding factors between the groups. Here you can see the procedural steps. The block is performed intraoperatively at designated parogastric points surrounding the gastric sleeve. We can see the anterior vagus nerve here, and we start behind the vagus nerve, almost 3 milliliters of injection at the end of sleeve resection. Technique is relatively simple, reproducible, and can easily be integrated into routine bariatric surgery without significantly prolonging operative time. Actually, it is almost 1 to 2 minutes, sometimes less, after we finished gastric sleeve resection. Our primary outcomes were pain scores at postoperative 0 and 2 second hours. Secondary outcomes included overall pain scores progression, nausea vomiting scores, opioid requirements, antiemetic use, and mobilization time. There were no statistically significant difference regarding age, BMI, or gender distribution between the groups. And now the key findings, the PG block group demonstrated significantly lower pain scores both at 0 and second hours postoperatively. And the nausea, vomiting severity was also dramatically lower. You can see the scale of pain scores in the first 24 hours. And also in the beginning, the nausea, vomiting scores were significantly lower in the PG block group. When we analyzed pain and nausea over time, the strongest benefit appeared during the early postoperative phase. This is clinically important because first few postoperative hours are usually the most difficult period for these patients. At 12 hours, the PG block group showed a paradoxical increase in nausea vomiting, which was not mentioned in previous studies. The differences gradually decreased later, which makes sense considering the pharmacologic duration of the local anesthetic. We also observed a clear opioid sparing effect. 30% of PG block patients required no rescue opioids compared to only 6% in controls. Similarly, 70% of PG block patients required no rescue antiemetics compared to 25% in controls. And patients in the PG block group mobilized much earlier. Average mobilization time was approximately 130 minutes versus 190 minutes in controls. Earlier mobilization is not only good for comfort, it may also reduce thromboembolic risk and shorten hospital stay. To conclude, parogastric block appears to provide effective early control of visceral pain and postoperative nausea after sleeve gastrectomy. It significantly reduces opioid and antiemetic requirements and supports faster postoperative recovery. Based on these findings, we believe PG block can become a valuable component of enhanced recovery protocols in bariatric surgery. Thank you.
Yeah, thank you very much, and congratulations on doing a double-blind randomized trial. I was wondering, I could not find it in the paper what was the study design? Was it a superiority? And as you had two different time points, so how did you use that for calculating your power?
We used G-power analysis, it was...
But I mean, you have 2 time points, the pain at 0 hours and the pain at 2 hours. So what was the difference? Was it a superiority or not? What was the study design?
We included 210 patients total, but in our analysis, the total numbers in both of them less than that. So we included enough patients.
That was a superiority trial?
Yes, superiority.
Okay, thank you. Yep, then we move on. Thank you very much. So next we are moving on to Jose Ignacio Martinez Montero, and he's going to present preoperative hepatic fibrosis score and diabetes remission after metabolic bariatric surgery. Please.
Thank you for the presentation and to everyone attending this session. I am Jose Ignacio Martinez Montoro from Virgen de la Victoria University Hospital in Malaga, Spain. I have nothing to disclose regarding this presentation. As you know, type 2 diabetes and MUSCLE-D share common pathophysiological mechanisms and have an influence on each other bidirectionally. MUSCLE-D is very prevalent in type 2 diabetes, and at the same time, type 2 diabetes is an independent risk factor for the progression and the severity of MUSCLE-D. Today, metabolic surgery is the most effective treatment for the management of both type 2 diabetes and MUSCLE-D, with very high rates of improvement and even resolution of these 2 conditions. However, we have very few data on the role of preoperative MUSCLE-D in type 2 diabetes remission after metabolic surgery, particularly using non-invasive biomarkers. There is agreement that liver fibrosis is the main determinant of hepatic and extrahepatic complications associated with MUSCLE-D. So this parameter, this outcome, liver fibrosis, should be the target of the screening of the disease. So in this study, we evaluated the association between the preoperative hepatic fibrosis score, which is a non-invasive scoring system used to evaluate the risk of advanced or significant liver fibrosis, and type 2 diabetes remission following metabolic surgery. We hypothesized that a preoperative hepatic fibrosis score below 0.12, which means or is associated with a low risk for advanced liver fibrosis, would be associated with a higher probability of diabetes remission following the surgical procedure, because these interconnections between these two entities, these 2 conditions. Here we show the PAMED fibrosis score calculator. This score includes several clinical and biochemical parameters such as sex, age, type 2 diabetes status, the calculation of insulin resistance, just in the case the patient has no type 2 diabetes. The biochemical parameters include aspartate aminotransferase, albumin, and platelet count. This score system was developed about 5-6 years ago, was specifically designed for assessing the risk of liver fibrosis in the context of metabolic disease or metabolic risk. So when we calculate the score, we obtain a result, and depending of the result, we obtain a different risk for advanced liver fibrosis or significant liver fibrosis. So, as you can see in the image, a score below 0.12 means a low risk for significant liver fibrosis. So, continue with our study. We included a prospective cohort of 145 participants with obesity and type 2 diabetes undergoing metabolic surgery in our center. They had a 1-year follow-up period. We calculated the baseline preoperative hepatic fibrosis score, and we evaluated type 2 diabetes remission following this period, 1 year. So these are the baseline characteristics of the study population, also the overall study population, and also classified regarding diabetes status 1 year after metabolic surgery. As you can see, there was a predominance of women in the cohort, and the type of surgery was predominantly sleeve gastrectomy. Also, type 2 diabetes duration and the percentage of patients using insulin therapy, the number of glucose-lowering medication and glycated hemoglobin were significantly higher in the non-remission group at baseline. As expected, these are very well-known predictive factors associated with type 2 diabetes remission after metabolic surgery. And also, we calculated HEPA-MET fibrosis score and other non-invasive liver fibrosis score, and we found that only the HEPA-MET fibrosis score was significantly different in the two groups. So this score was significantly lower in participants who achieved type 2 diabetes remission, the score at baseline. These are our main results. We found that among participants with a low HEPA-MET fibrosis score below 0.12, meaning a low risk for significant liver fibrosis, more than 70% achieved type 2 diabetes remission after metabolic surgery, compared to a 52% in the group with a higher HEPA-MET fibrosis score over 0.12. This difference was statistically significant. So that means a 41% higher chance of diabetes remission in the low HEPA-MET fibrosis score group as compared with the HEPA-MET fibrosis score group with a score over 0.12. And this association remains significant after adjusting for potential confounders such as type 2 diabetes duration and the number of glucose-lowering medication, baseline glycated hemoglobin, and other potential confounders that are associated with type 2 diabetes remission after metabolic surgery. And to conclude, we can say that in this study we show for the first time an association between the baseline HEPA-MET fibrosis score prior to surgery and type 2 diabetes remission after this surgical procedure. These results reinforce the interconnection and the bidirectional relationship between these two conditions. However, further research is needed to confirm these results and to validate these results in independent cohorts, also including longer follow-up and a higher proportion of different surgical techniques, such as gastric bypass. However, we think that the HEPA-MET fibrosis score is a simple and accessible non-invasive biomarker that could become a useful tool complementing other existing predictors, well-known existing predictors of type 2 diabetes remission after metabolic surgery. Thank you very much for your attention, and enjoy Malaga.
Thank you very much. Any questions from the floor? Gerhard?
Great study. Did you do intraoperative liver biopsy to validate the score, as histology is the gold standard, and you are in any way?
Yes, we only have biopsies for a subset of participants. So in this study, we were not aiming to describe or to assess the association between directly muscle D evaluated by liver biopsy, but the risk of significant liver fibrosis. So this is a limitation of our study. But as I said, the main goal, the main objective was just to assess this as a non-invasive biomarker.
Francois?
Thank you very much. I have two questions. The first one, the HFS is the only one of the 4 liver tests that you studied which has glucose in it. The other one just don't have any dysglycemia, so it might be quite intuitively predictive that the one who is assessing glucose is better predicting. You said it was independent from A1C, so you did multivariate analysis?
Yes.
Anyway, okay, but this is, of course, an important point, because there is glucose in the test. My question is, you are telling about a biomarker. So it's good to have an association, but it would be good to have a metric that tells you the predictive value, AUC. Have you done that? What is the value of the area under the curve in a logistic regression?
Thank you for your question. Yes, the HEPAMET fibrosis score includes some glycemic parameters. However, as all the participants had type 2 diabetes, the HOMA-IR, insulin resistant, was not introduced in the calculator. So just sex, age, and the biochemical parameters, aspartate aminotransferase, albumin, and platelets were included. And diabetes status, as all participants had type 2 diabetes, all of them scored 1 point in the score. So, and in response to the second question, we are working on that. These just preliminary results, and we are working to evaluate the predictive capacity of this score alone and also in association with other known parameters associated with type 2 diabetes remission. I can say that the predictive value of the score is near to 0.7, but when combined with other parameters, this predictive capacity.
So I understand it is less than 0.7.
Yes.
Okay, so 0.7 is really the limit for any clinically significant thing. Any biomarker which is useful is 0.9. So we have to be careful here to not mix. Okay, thank you very much.
Thank you very much.
Well taken notes, okay. Thank you very much. We'll go on. We are running a little bit out of time. We invite Paula Richtveen is here, okay. Paula from the University of Wien. Microvesicular hepatic steatosis in patients with obesity. Implications for diagnostic and treatment eligibility. Please.
Thank you very much for the introduction. My name is Paula Richtveen. I'm a surgical resident at the Medical University of Vienna, and I'm very happy to present you our results concerning microvesicular steatosis. Doesn't work. Okay. I have nothing to disclose. As we already heard, muscle D is highly prevalent in obesity, and up until 2024, the only available treatment or possibility was to reduce weight by more than 10%. What is the gold standard for the diagnosis of muscle D? It's still liver biopsy. And there are two main scores being used for the diagnosis. One was published by Kleiner et al. In 2005, which divides hepatic steatosis into 3 grades. And then, together with lobular inflammation and ballooning, creates a score where you can say if it's muscle D, MASH, borderline MASH, or no MASH. And in 2012, Bedossa et al. Created a score that took this steatosis grading and made a cascade also for the diagnosis of muscle D and MASH. So if we look at it closer, the histology or the scores only focus on macrovesicular steatosis. So what you can see here with the green arrow is large droplet macrovesicular steatosis, and in the blue arrow, it's small droplet macrovesicular steatosis. Those two components are taken into consideration in the score. But what is usually described by hepatopathologists is also microvesicular steatosis. It's always described, but never is part of the score. And what do we know about this microvesicular steatosis? There are quite few studies and small cohorts, but up until now, what we know is that it's present in 10 to 30% of people with obesity, and it may serve as a marker for a more aggressive disease. But what is the problem? As you can see here in this picture, there are people who have quite little macrovesicular steatosis, as in this picture, maybe like 10 or 15%, but have a lot of microvesicular steatosis. As you can see here, maybe 85, 90%. But this patient would only receive steatosis grade 1. So the question is if in these patients we're underestimating disease severity. And this is especially important as since 2024 there is a drug for the treatment of patients with MASH and F2 and 3. And right now there is also under discussion the extension for the treatment eligibility for patients that also have F1. So our study aim was to assess if we're underestimating disease severity by ignoring microvesicular steatosis. So what did we do? We performed a retrospective cohort analysis looking at 878 patients that underwent bariatric surgery who all received liver biopsy. And we looked at the NAS and SAF scores, our hepatopathologists scored, and we implemented a new overall steatosis score that included microvesicular steatosis. And then we also looked at the different groups if there were significant differences. Coming to the results, here you can see our demographics. That is quite common bariatric demographic. We had more female. The median age was 41 and the median BMI was 45. Here you can see the procedures we performed with leading procedures being OAGB and Roux-en-Y gastric bypass. And here you can see the histological characteristics. So the median macrovesicular steatosis was 30%, whereas taking overall steatosis into consideration, the median was 40. As you can see in the graph, the score, the steatosis grade turned to the worse when looking at overall steatosis. And what is important, mixed steatosis was present in 47.7% of our patients. So 47% had microvesicular and macrovesicular steatosis. Only a very small amount, only 4.1% had isolated microvesicular steatosis. What is important here is that we saw microvesicular steatosis in almost half of our patients. So this is not a rare finding. This is in half of our patients. And when looking at associations, we saw that the isolated microvesicular steatosis had a tendency to be more present in younger patients, more in female patients, less in type 2 diabetes, and when looking at the mixed steatosis, it turned a little bit to the sicker and older patients. So the question is if isolated microvesicular steatosis might be an earlier disease stage. And when looking at MASH distribution, we saw that when looking at the conventional NAS, 26.5% of the patients had MASH. And when looking at the overall steatosis score, over 30% were diagnosed with MASH. So why is this important? As we saw, the NAS was strongly affected and SAF was a little bit more stable. And now, if we look at the eligibility for resmetirom therapy, when looking at the standard criteria, so MASH with F2 and F3, we didn't see a significant difference between the two groups, but in all the studies, or right now, it's under discussion that F1 patients are also included. And there we saw an increase in, a significant increase in patients that would be eligible for resmetirom therapy. Exactly 47 patients were eligible. And the question is, who are these patients and who is currently not receiving therapy? And what we found was that the biggest difference was in premenopausal women. So we don't really know if this is, so we need to do further studies because obviously we have limitations. This was a retrospective study design. We had a small isolated microvesicular group and few advanced fibrosis cases. So to conclude, microvesicular steatosis is very common. It's associated with MASH and it may improve diagnosis and therapy access, especially for young women. But obviously clinical relevance is needed. Thank you very much.
Thank you very much. Thank you very much for your study. So to be understood that you are taking biopsies to all the patients, or which is exactly the protocol? One.
Yes.
And secondly, I've noticed that almost half of the patients are revisional surgery. Do you notice any difference between primary and the revisional surgery?
So we take biopsies in all our cases. In revisional surgery, we only take biopsies in the patients who already had biopsy before, and only 5.6% of the cases were revisions. Here you can see it was only 5% revisions,
5%.
and it was revisions due to recurrent weight gain.
So you are taking to all the patients?
Yes, we take biopsies in all our patients. Yes.
Okay. So, any question? Please.
Because we know that it's important because many people have advanced fibrosis, and we want to give them better opportunity to receive further treatment. We refer them all to hepatology department if they have advanced fibrosis, and we also make a closer follow-up for these patients.
That's an institutional protocol, and we are
Yes.
grateful for
Yeah.
this. There's no comment on this. Thank you for sharing with us. Thank you.
Thank you. We move on. Next speaker is Felipe Amorim Cruz. Beyond weight loss, multidimensional outcome assessment after metabolic and bariatric surgery using SF-Bari score.
So, good afternoon, everyone. My name is Felipe Amorim Cruz. I'm from São João University Hospital in Oporto, Portugal, and I wanted to take you beyond the weight loss and scale and present you the research work entitled Beyond Weight Loss, Multidimensional Outcome Assessment after Metabolic and Bariatric Surgery using SF-Bari score. I have no financial disclosure or conflicts of interest related to, sorry, it's not working? Yes, sorry. I have no financial disclosure of conflicts of interest related to this presentation. And to start with, metabolic and bariatric surgery is the most effective treatment for severe obesity, producing significant and durable improvements in weight and metabolic health. However, there are large variations in treatment response after surgery. And as stated in IFSO 2024, reporting in our field remains inconsistent. And there are large variation in terms of how we report success in sufficient weight loss, weight regain. And in fact, there is a lack of uniform standardized reporting definitions with a heavy reliance on weight loss metrics. And so maybe we need to try to think about what is the real question. Are we measuring what truly matters? Why weight loss alone is no longer enough? Our own data presented at last year's SECO Congress show that common cutoff, such as 10% total weight loss, is a poor predictor to actual clinical response, failing to capture the comorbidity persistence or the need for reparation. The 2025 paper by Pierre Roser reinforced this. BMI alone does not reliably reflect the disease severity. And so the shift from bariatric to metabolic surgery demands a tool that prioritizes disease burden over anthropometrics. And this theme is not recent. Back in 1998, Biosystem attempted to address this, but never gained some traction due to an impractical classification system. And so in 2023, the SF-Bari score comes up by Paulina and her collaborators, trying to solve these limitations. Derived from the two XCTs in obesity surgery, the SLIFPAS and SM-BOSS, it integrates three domains that we need: weight loss, comorbidity resolution, and surgical safety, producing a continuous score categorized into 5 levels. So the aim of our study is to evaluate the applicability of the SF-Bari score for holistic outcome assessment in our large real-world single-center cohorts. And the second aim is to identify predictors related to a good or better response in the SF-Bari score. This is our population, patients submitted to primary MBS between 2019 and 2023. This is our exclusion criteria. In terms of the data collection, all the metrics to calculate SF-Bari score were measured, and this is the 5 levels that I already talked about. In terms of the data analysis, we used violin plots and alluvial diagrams to see the data visualization over time, and we used the logistical regression to identify predictors of a favorable clinical response defined as a good or better score at 12 months. So, in this study, the cohort, we included 2,507 patients, permanently female with a median BMI of 41. The main patients underwent gastric bypass, while 13% have had sleeve gastrectomy. In terms of the multidimensional outcome, the median total weight loss was 35%, in which only 4% had total weight loss lower than 20%. The SFR score outcomes were classified as excellent in 5%, very good in 37, and good in 52. With basically 60% of our patients achieve a good or better response. And with these violent plots in your right, you can see that the clinical response improves significantly over time, with a median SFR score increasing from 6 months to 12 months, confirming that the metabolic benefits continues to consolidate well beyond the early postoperative period. And with these alluvial diagrams, you can capture this shift at an individual level. At 12 months, 60% patients achieved a favorable clinical response, and most of the patients that were classified in the beginning as fair or suboptimal progressed to a good or better score by 12 months with few deteriorations. And in terms of the factors related to a good response, it seems that younger age, absence of baseline comorbidities, patients undergoing gastric bypass, and also a shorter waiting time between the first consult to the primary surgery were all significant positive predictors. So the main findings of this study is that SFR score is applicable and feasible tool for real-world multidimensional assessment. The majority of our patients achieved a good, very good, and excellent outcome, and most patients showed a stable or improving score at 12 months. What are the next steps that we need to think about? This is a retrospective study with a 12-month follow-up window, so we cannot yet assess the suboptimal clinical response to the current weight gain. Our data lacked a limited quality of life assessment, and because of that, the psychological benefit may be underestimated. And so to conclude, the SFR score is feasible for multidimensional outcome, and bariatric surgery outcomes should move beyond the weight loss metrics towards a more comprehensive assessment of overall health improvements. Thank you so much.
Congratulations. Question from the floor? Anyone? I was watching the data, and at 6 months, not insufficient, the suboptimal response was very low. Is it the same with other?
Sorry, I didn't understand.
At 6 months, the suboptimal response was very low.
Mm-hmm.
Is it continuing up to which?
Yeah, it seems. Yeah, it seems like that. At 12 months, the suboptimal clinical response is maintaining low, and as you can see at the alluvial diagrams, there the improvement of weight loss and the score, it's even better. So yeah, it seems the tendency. It seems that yes.
Any other questions? I may be biased, so.
So you can. A little bit. Hi, thank you very much for this. My question is, how much of the SF barrier score is driven by weight, and how much is driven by comorbidities? So if you, you see my question.
Thank you for this question. Actually, the SF bar, I didn't show it here because to the time, but we did Pearson correlation, and what you can see is that the SFR score, the 67% of variance in terms of SFR score is correlated with total weight loss. But the other percentage is related to the other elements, the other metrics. So that's why taking beyond the weight, it's very important.
Happy with the answer? Yes. Okay, we continue. Thank you very much.
Thank you.
Dr. Room from the UK is here. Okay, please step up and light it up about the founding and the patient's choice of selecting bariatric and metabolic surgery.
Yes, and thank you very much.
Very interesting topic, please.
Thank you very much for the opportunity to present. So yes, my name is Hal Room. I'm a bariatric surgeon in the UK, and I'm presenting on behalf of myself and my colleagues at from the East Suffolk and North Essex NHS Foundation Trust. And we have looked at whether prior self-funding of obesity management medication, specifically GLP-1 medication, impacts patient choice between bariatric surgery or obesity management medication when they come into our NHS service and have availability of both treatments with equal access and free at the point of need. So our service is a new service that was set up 2 years ago, and it's the first unit that's been set up in the UK in the last 20 years. We cover Suffolk and Essex counties. It's an area of higher than average obesity rates, high deprivation, and historically has had fairly poor provision of obesity services. So setting up this new unit gave us the opportunity to develop new models of care, new ways of conceptualizing obesity services and follow the latest guidance. And as we were setting this up in 2023, 2024, there were lots of people saying that GLP-1 medications were going to replace bariatric surgery, that GLP-1 medications should always be the first line treatment, and that indeed patients would always prefer GLP-1 medications rather than surgery. And so it took a lot of courage, I think, to try and stay the course and say that we wanted to have an integrated unit where we offered both bariatric surgery and GLP-1 medication with clinical equipoise and free at the point of need. And so we did manage to do that. We have a single unified assessment pathway assessing patients' suitability for both GLP-1 medication and for bariatric surgery, and allowing the patients to select their preferred treatment and informed with the same patient education, the same shared clinical decision-making, and equal criteria for access for both treatments. And obviously, because it's the NHS in the UK, there's no cost to the patient, so there's no financial bias as to what treatment they choose. So our aim is to get the patients to the single best treatment and to support their preference for which treatment they choose. Whereas elsewhere in the UK, there are many services that can only offer one or the other treatment, or they might have different eligibility criteria, or waiting times might differ, and obviously the time that you have to wait for treatment might significantly impact the patient's choice of treatment. So our unit is in a unique position to look at and research and report patient treatment choice when both treatments are provided equally. And we have a single preparation pathway and an MDT decision-making, and we then have a surgical or a medical pathway for patients to have one or the other treatment. And occasionally we treat patients with both in our hybrid pathway to have GLP-1 medication first and then bariatric surgery later. Now, last year we presented patient choice research with the first cohort of around 400 patients that came into our service, and we presented this in Venice last year, and we showed that 58% of patients, when offered both bariatric surgery or GLP-1 as the two alternatives, 58% chose bariatric surgery, and 41% chose GLP-1 medication. And so therefore, bariatric surgery remained preferred as the first-line treatment by the majority of patients, despite the GLP-1 agonist medications becoming a new treatment option over the last few years. As we then went forward over the last 12 months, we noticed an increasing number of patients coming into our service that had chosen to start paying privately to self-fund GLP-1 medications before they entered our service. And so we wanted to ask the question, how does that prior self-funding of GLP-1 medications affect patient treatment choice when they get to the point of being able to either have bariatric surgery or GLP-1 medication? And so we retrospectively analysed a new cohort of 260 patients that entered our service over the last year, and we routinely collect that self-funding, the information in our patient health questionnaires as to whether patients have begun self-funding GLP-1 obesity management medication before they enter our service. And here we're specifically talking about either Wegovy or Mounjaro. And all patients receive the same appointments, the same patient education, the same treatment choice information. And so it's reasonably unbiased management of patients. And they're free to express their treatment preference. And so for this new cohort of patients that we've looked at, approximately a quarter had self-funded GLP-1 medication before they came into our service, versus 3/4 that had not had any, that were treatment naive and had not had any previous exposure to GLP-1 medications. Of the 1/4 that had self-funded GLP-1 medication, we found that 42% chose to continue obesity management medication, then provided by our service free at the point of need. Whereas 57% chose to actually stop their self-funded medication, their self-funded GLP-1 medication, and undergo bariatric surgery. Conversely, the 3/4 of patients that had not had previous GLP-1 medication exposure, 55% wanted to commence treatment with GLP-1 medication, and only 44% chose to have bariatric surgery. And therefore, previous self-funded GLP-1 obesity management medication was associated with an increased likelihood of patients choosing bariatric surgery in our service when both treatments were offered free at the point of need with equal access. And that increased likelihood was 30% higher if they had had GLP-1 medication self-funded previously. And this was significant. But I then looked at, were there any factors that could predict whether a patient would choose to have bariatric surgery if they had been previously self-funding GLP-1 medication. And there was no individual factor such as pre-treatment BMI or age or gender or comorbidity that was associated with that choice. Patient choice is, I think, a very complex thing to understand. The only thing that I did look at and that I think we need to explore further is whether the duration of self-funded GLP-1 medication impacts patient choice. And we don't routinely collect that in a structured way, but we are going to start doing that. But we did have self-funded treatment duration available for some patients. And although nothing was statistically significant, anecdotally, I did see that the patients that were choosing bariatric surgery in our service, where they had previously self-funded their own GLP-1 medication, were often patients that had either only been on GLP-1 medications for a short period of time, but were then having side effects or were not having weight loss, and therefore they were choosing bariatric surgery because of that, or they had been on GLP-1 medication for a long time, and their weight had plateaued, and they were converting to bariatric surgery because of that, of wanting to have further weight loss. So that's something we're going to look at. But the overall conclusion is therefore that patients that have previously self-funded GLP-1 medication are more likely, or is associated with an increased likelihood of patients choosing bariatric surgery when they get into our service and have availability of both bariatric surgery and medication offered equally free at the point of use with clinical equipoise. And therefore, generalizing, it may well be, therefore, that widespread GLP-1 medication availability may, in fact, increase the number of patients that subsequently seek bariatric surgery. Running out of time, but there is one major limitation to this study, which is that in the UK, Wegovy is limited to a maximum of 2 years of treatment, and our current funding contract limits our use of GLP-1 medication to a maximum of 1 year, unless there are exceptional clinical circumstances. So we are going to do some further research on this, particularly looking at the duration of self-funded GLP-1 medication and how that impacts patient choice, and have some patient focus groups, and we'll look to publish this fully in due course. So I think I'll conclude there, and thank you very much to the whole team that supports us and enables our unit to run to make all this work. Thank you.
Thank you very much. Well, unfortunately, there is no time for the questions. But your study is very interesting, and we invite you to search, continue to look at inside to the questions you already raised, to look at which are the particular aspects of those patients who intended to act in this respect. So that's
Yeah, I
there
think
are further questions.
patient treatment choice is so complex that we need a bigger data set and lots more research, yeah.
Thank you.
Yeah, but it's optimistically saying it is good. Thank you very much.
Thank you.
So we are then next presenter will be Viikko Vahtera, and they will present effect of metabolic bariatric surgery on alcohol use, an 11-year prospective follow-up study with matched controls.
Thank you for the introduction to the chair, and thank you all. So, a couple of words about the effect of bariatric surgery on alcohol consumption. I have nothing to disclose. So as an introduction, both excessive alcohol intake and obesity are key public health concerns. And high alcohol intake, in particular binge drinking, and alcohol-related loss of consciousness is associated with higher risk of obesity, hypertension, and dyslipidemia. And alcohol-related passing out has been associated with an increased long-term risk of dementia, even at moderate levels of alcohol consumption. We know that bariatric surgery can have negative effects among alcohol users, for it accelerates alcohol absorption, it increases the peak blood alcohol concentrations, and it lengthens the time of sobering up. And bariatric surgery therefore leads to a higher risk of problematic alcohol use disorder, and alcohol-related hospitalizations also in long term, as stated in various studies before. So we made this nested follow-up study inside of a Finnish public sector study, which is a huge cohort of Finnish public sector employees with over 500,000 participants. We searched for all the participants responding to at least 2 surveys measuring alcohol use, and we asked about the amount of consumed alcohol passing out due to the alcohol use and the types of alcohol consumed. Then we made a propensity score matching, and we were able to control many very important confounding factors. And in the end, we have 362 laparoscopic patients, and for them, 2 theoretically identical controls. The weight decreased as expected. Those who were non-drinkers before the operation, they continued to be non-drinkers. But the average consumption of alcohol began to increase after bariatric surgery from 2.8 units per week until the 4.2 units per week. And the standard unit of alcohol is 1 bottle of beer, 1 glass of wine, or 4 centiliters of spirits. The prevalence of moderate or high consumption started to increase significantly, and the people started to reporting passing out due to alcohol use in bariatric surgery group. When assessing the types of surgery, the gastric bypass patients reported more of the increase in average alcohol consumption, and also they reported more passing out while drinking, but we didn't have enough sleeve gastrectomy patients to make strong conclusions here. The most interesting finding in the study was that these individuals who had very low consumption in the beginning, only 2 or less units per week, they also started to increase their drinking over a little bit more than 3 drinks per week, but they significantly started to pass out more during the years of follow-up. When assessing the alcohol types consumed, the increase was mainly seen by drinking some wines and beer, but not so with spirits. Our study has limitations. It's based on self-reported alcohol use, and alcohol induces loss of consciousness, and it bases on self-reported height and weight. People might misreport sleep after excessive alcohol intake as alcohol-related loss of consciousness. And small number of patients with sleeve gastrostomy prevents us to do strong conclusions, as said before. And last, our study is ethnically homogeneous female-dominant occupational cohort from a single Scandinavian welfare country with certain types of and patterns of alcohol use. So as a conclusion, the overall alcohol consumption increased and alcohol-related loss of consciousness increased after bariatric surgery, while alcohol use declined among controls with severe obesity. Even modest increases in alcohol use after bariatric surgery may lead to greater alcohol exposure and intoxication risks, and seen in our study also. And these findings highlight the importance of monitoring alcohol use after bariatric surgery, even among these so-called low-level alcohol users. I thank you for your attention.
Thank you very much. And can I ask the scientific committee to start their assessment now, while Vico is taking their questions? No, they'll manage. So, any questions from the floor?
Thank you for this very nice study. So in your current practice, when you have a patient with a history of alcohol abuse, do you contraindicate the gastric bypass, or do you still propose a gastric bypass?
Thank you. Excellent question. We have a multimodal team working with the bariatric patients, and we try to figure out who have problems with alcohol before. We try to root them out. So we would have a patient with a problematic alcohol use. We would still choose the bariatric procedure which would be better to the patient, but we would certainly follow up, we would certainly keep our eye in the alcohol problems, and the people, they should be warned about the problem, because the person may have an alcoholic problem before, but and they may be at the remission with the disease, but they can have a relapse, and it's of course very bad for the patient.
But I mean the technique, is it part of your choice? Would you prefer to do a sleeve in case of a history of alcohol abuse previous to surgery?
It depends on the patients, highly. It's still, if had an alcohol problem afterwards, it's the worst. It's bad with the sleeve also. We know that also. So the alcohol problem with obesity and after bariatric surgery is a bad combination anyway. So.
Thank you. What's the question about which technique? She answered or they answered.
Yeah.
Please.
Did you track de novo alcohol use and how it impacted me? And the implication being that perhaps it's not just pharmacokinetic absorption, but perhaps psychologic addiction issues, food to alcohol?
Yeah, we did actually, in the propensity score matching, we took very many the psychological factors also were included. So they were quite similar to patients and the cases in different kind of psychological parameters also, but we didn't actually take a look at that.
Thank you for excellent study. Two short questions. Is there a risk that there is a little bit of selection bias, that patients having MBS would be a little bit more vulnerable compared to the others? They seem to be quite equal from the baseline. That's the first part. And the second part is, with the new data coming this last week or so, that we have semaglutide decreasing the risk of having alcohol use, would that be an idea to have be very fast on introducing a low dose of semaglutide if you have alcohol problems?
Thank you for the two questions. I'm a simple surgeon, so I try to remember them both. Yeah. So we actually can't have a selection bias because the patients are taken from the huge public sector cohort. So we only take the patients who had a bariatric surgery and all the measurements done also beforehand of the surgery, 2 years before the surgery. So the controls are as they are. And the second ones I already forgot, so.
We will see.
The OMMs, that would it be a good idea to start semaglutide in a
Yeah,
small
it would
dosage?
be excellent idea to start with that.
Excellent. Thank you very much.
Good.
So I just want to shortly announce while the scientific committee is doing their work that we have 3 prizes. All of the presentations were excellent and I congratulate every single one. But there will be 3 prizes. So first prize will be $1,000 and, sorry. That's why I have it here on my, no pounds. 1,000 euros and a free registration for the Munich Congress. And the second prize is 500 euros and free registration. And number 3 will receive free registration for the Munich Congress. So I give the floor now to the chair of the scientific committee to announce the prizes. Are you ready? Okay. That was like a short pause, they were thinking. Okay, so maybe you start with, do you want to maybe 3rd place?
Okay.
Yeah, they said they were ready.
So if I may add, the analyze was not only the content of your paper, but also the way you presented, and the time that it was allocated for. So there were many considerations, and they are very objective. So let's see. Why it's your mimic changing, right? Yeah. Yeah, but everybody is a winner here. We addressed this from the very beginning.
Okay.
Being here qualified, it's a prize.
Okay, so Professor Marco Buter.
Yes, so it was, as you can see, intense discussions. So I start with place number 3, which would be the presentation number 3, which would be the baseline microbiome signatures and clinical factors predicting weight loss response after Roux-en-Y gastric bypass by Mr. Morante.
Can you please stay there so we can take a picture? Thank you.
The second place was also intensively discussed, but it's going to the 2 ladies presenting the 25 years of randomized clinical trials from Finland and Austria.
Congrats. Congrats. You go there?
Congrats. And the first place was actually the first presentation, which was the ambulation after metabolic bariatric surgery-induced weight loss long-term results from the SOS study by Mr. Svensson.
And we will take a picture with the winners, and we will you will get the prizes from our CEO for IFSO. But at this point, I want to thank everybody for a wonderful Congress here in Malaga. This will be our final session before the gala dinner. So thank you very much for staying. Yeah, we will take a picture. Yeah. No, but let's take one with that. Yeah. Yes. Thank you.
Thank you.